So this is a topic about newborn jaundice. So jaundice is defined when the total bilirubin is greater than 5. Anytime you see in the question total bilirubin greater than 5 and newborn, think about jaundice. So there's two types, physiologic and pathologic. Pathologic jaundice is always, it show up less than 24 hours. And physiologic, it show up between the 3rd to the 8th day. So it's never in the first day. If the newborn has jaundice within the first 24 hours, it's always pathologic. So there are a few facts you can see whether it's physiologic or pathologic. Physiologic is always unconjugated. Pathologic is unconjugated or conjugated. And the next thing is level. The total bill is less than 15 here. Patho is greater than 15. And then physiologic, a daily rise in bilirubin is less than 5. Daily rise in bilirubin greater than 5 is pathologic. And pathologic, you also have to look for risk factor. So look for premature, low body weight, history of siblings with same condition, fetal maternal blood incompatibility, and blood trauma. So that's in terms of the level. So again, the day is 3rd to 8th day, less than 24 hours. Level is 15 is the gold number. Total bilirubin less than 15 is physiologic. Total bilirubin greater than 15 is pathologic. In terms of the timeline, as I said before, if it's less than 24 hours, it's always pathologic. Physiologic is asymptomatic and transient icterus between 3rd to 8th day. Pathologic is less than 24 hours and it can go up to week 1 in the term pregnancy and week 2 in preterm. Next up, physiologic, there's 2 variants, right? So the first variant is breastfeeding is within 1 week because it's not enough milk. So it will present signs of dehydration. And what you have to do is increase in feeding. Breast milk is within 2 weeks after birth and lasts for 4 to 13 weeks. Because breast milk jaundice is because in the milk, it has increased beta-glucuronidase. I forgot what the enzyme is, but that enzyme is increased. So that's why the patient has been having symptoms. So you just have to increase in feed. So this is a chart for different causes. So if you see here, this is like physiologic is breastfeeding or breast milk. Pathologic is either unconjugated or conjugated, right? So unconjugated is the cause is hemolytic or non-hemolytic. Hemolytic, infection, sepsis, hematoma because of the vacuum use, and vitamin K deficiency. Hemolytic disease or newborn is we know ABO incompatibility and RH incompatibility. So the way to distinguish these two is RH is always Crohn positive, ABO is Crohn negative or weak because this is not autoimmune, right? And then on the ABO, you will see a spherocyte. And hemolytic, you have a spherocytosis, hereditary spherocytosis, and G6PD deficiency. Non-hemolytic, it has to be the enzyme, the gluconal transferase deficiency, right? So it's either Crigler-Najjar or Gilbert syndrome. Pathologic conjugated is either because of decrease in bilirubin secretion or intrahepatic pathology. Dubin Robert Johnson, rhodogalactosemia, intrahepatic pathology. Decrease in bilirubin excretion is because of the intrahepatic cholestasis, sepsis, Hepatotosh, cystic fibrosis, or extra bilirubin obstruction. The most common is biliary atresia. Then choledochosis and tumor and stricture. So this one is high yield because this jaundice baby will have a prolonged, so the question will say a baby coming with prolonged jaundice for more than 2 weeks and it has a conjugated hyperbilirubinemia with a colic stool, dark urine, hepatomegaly, increase in AP, and increase in LFT. So you choose this if you see jaundice plus a colic stool, dark urine, hepatomegaly, and liver enzyme abnormality, right? So that's very unique. And I have more information about the biliary atresia. So if you suspect biliary atresia, the best next step you do is ultrasound. If ultrasound is ensured, you can do HIDA after injecting with phenobarbital, and then you see no bile to duodenum because biliary atresia basically mean there is no bile duct, mainly common bile duct is absent. So even if you're still unsure, you can do an intraoperative cholangiogram to make sure that this is biliary atresia. The surgery you do is you connect the liver, you cut out the disease part of the common bile duct, and then you connect the liver directly with the intestine, and you connect the intestine with the stomach. So that is called hepatoportoenterostomy. And this procedure is called Kasai procedure, and this usually solves the jaundice in neonates, but they usually end up getting the liver transplant by 2 years of age. So this is an emergency. You have to treat it right away. If you don't, you can get primary biliary liver cirrhosis within 9 weeks. And in terms of the treatment for jaundice, the first is phototherapy. You only give phototherapy only if the total bilirubin is greater than 95% on nomogram or greater than 50 milligram per dl in first 48 hours, greater than 20 in the first 96 hours. So either 15 in 48 or 20 in 96. This phototherapy is only for unconjugated hyperbilirubinemia. You do an exchange if the level is really high. Instead of 15 in 48, so basically this is 7.5 in 24 hours. If the baby has more than 20 in 24 hours, you do an exchange transfusion. Or anytime it's not responsive to phototherapy, anytime you have CNS symptoms, anytime you have severe anemia or hemolytic disease. The next step is giving IVIG. IVIG is the choice for the blood problem causing significant jaundice or immune-mediated diseases. So this is the neonatal jaundice. The biggest thing you have to do when you see a problem with neonatal jaundice is first you check the total bilirubin, next you check the conjugated or unconjugated, and the third you can check the timeline. After that, physiologic you only have 2 causes. Pathologic you have a lot, but this is commonly tested. So if you see they mention stool, dark urine, or hepatomegaly, you choose biliary atresia.